Excellent. Well, thank you so much for having me today, and I'm especially excited to share with you some of our more recent findings from the laboratory, where we have been, for probably the last, 2.5 years working with different manufacturers of oscillatory airway clearance devices to assess the different factors and physical principles around their operation, and specifically around secretion mobilization, both on bench models and in our animal models as well. And so, we wouldn't be able to do a lot of this if it wasn't for some of the help that we get from our industry partners, which also include ABM Respiratory Care as well as Centec. And so we are super fortunate, especially during this difficult time of getting funding from our federal government. Things have shifted a bunch, and we have to always kind of give the people the credit they deserve who are funding our research. So thanks again for all of that. Also, I am serving for this lecture as a paid consultant from ABM Respiratory Care to discuss something that's fairly near and dear to all of our hearts as respiratory therapists, and that's going to be airway clearance therapy. So providing a little bit of background on this, what is the requirement for airway clearance therapy? Well, that's any patient who we think has some impairment in gas exchange, has ineffective cough, has inability to move the secretions from the distal lung region or the central lung regions up into the nasopharynx or up into the trachea, where it could be coughed out and expectorated. And so the patients that are going to require our intervention and our airway clearance therapies are obviously going to be those patients with excessive mucus production. And that's usually technically defined as something greater than, say, 25 milliliters of secretions per hour. Ineffective cough, this could be, anyone, who has impaired lung volumes, or, has neuromuscular weakness and is unable to get the secretions up effectively on their own. Some patients may have mucociliary dysfunction. There's lots of different diseases, especially in pediatrics, which I tend to focus most of my time on. There's certain things that can affect the way that the gel and the sol layer are projecting mucus forward through the airway. I just thought I'd share with you some of these interesting scanning electron microscope slides of the ciliated epithelial cells of the airway, where we see the cilia, and they're operating within a gel and sol layer, which serves as our mucociliary escalator. And there are situations, like pulmonary dyskinesia, impacted secretions, all of that can really have a significant impact on the mucociliary escalator and bronchopulmonary toileting, because the cilia have essentially, laid down and they're ineffective. This represents mucus that is trapped within that gel sol layer of the airway epithelium. And this is just a fun little image I show here of a patient that was very, very challenging in the pediatric intensive care unit a few years back, where we went down with a bronchoscope and we could see that there was significant mucus impaction. And then, in a nutshell, these are a lot of the patients that we really want to try to apply these different types of therapies to, especially the oscillatory techniques that we're talking about today, because we want to be able to mobilize those secretions. We also want to be able to share those secretions, and break them free of that gel sol layer, break them free of the airway lining, and propel them further up into the airway so that we can get them out. And so that is the goal. And, traditionally, at least at my institution, for a lot of years, we did CPT, and that was our primary form of airway clearance. And, I think what we've seen over the years is that there is going to be a lot of inter-practitioner variability with regard to how effective we do this with a hand. And then, you could use these mechanical percussors, and it's unclear whether they really do the job that's needed to be done in order to get the secretions out of the airway. There are folks who are doing, using vibratory techniques on the back, which I think are absolutely ineffective. Mainly because I've taken a lot of these devices and I've percussed the external chest cavity or sorry, the external chest wall with them. And this represents a pig that's being mechanically ventilated. And you can see based on the esophageal pressures, those are going to be your transpulmonary or pleural pressures rather, that very little of the hand clapping technique that I'm using on this pig, which I think was pretty rigorous, um, it they're vigorous rather, and that really was not transmitted into the pleural space, meaning it wasn't transmitted well across the chest wall or across the lung and into the chest wall. So you can see my little oscillations right here. And I always thought, hey, I'm a pretty good hand clapper. But when you take vibratory devices and you apply them to the external chest wall, you see even less of this. I will have to say that with a jacket though, and when you're percussing the external chest wall with a therapy vest, you do start to see a lot more of those pressure fluctuations, and that's a more effective way of removing secretions that I think honestly has really kind of replaced the hand clapping as well. And so we use a lot of that in our intensive care unit, mainly because it's a little more effective at removing the secretions. Now, there has been a proliferation of these oscillatory lung therapies over the last several decades, and I think, the one that stands out the most is going to be intrathoracic percussive ventilation, which is the device was developed by Bird and was used as now being promoted by Centec, and they have multiple versions of the device and different handsets, but in essence, all those devices have similar principles, and the waveform really doesn't differ from one of those devices to the other. And that has been kind of the standard, I think, for helping to recruit the lungs and mobilize secretions. We've seen the Metaneb and the Valera device, and now the Byways Clear, which we've been studying all of them for some time now. Now, what do these oscillations have to do with airway clearance? Well, the question is somehow that, we know that with high frequency oscillatory ventilation, we have enhanced gas distribution in the lungs. We're applying a higher mean airway pressure, and we're creating some resistance when we're applying those micro breaths. Now, high frequency oscillation doesn't really differ hugely from high frequency oscillatory ventilation, except that it's intermittent, and it's going to apply sustained rapid pulses of positive pressure. And in some cases, these tend to mimic micro coughs. Now, if we think about a cough, I take a nice, slow, deep inhalation, and then I increase my peak expiratory flow. And by doing that, the airspeed and the turbulence within the airway assists in the sharing of mucus from the airways, and helps to mobilize it outward. And so, this sharing effect could be enhanced in those patients that have retained secretions, or maybe they just don't have an effective cough. And so, in essence, they have been promoted as something that would assist in lung mobilization, share the mucus or break up the mucus from the airways, and then transmit it from the lower to the upper airways so that it can be expectorated. And, what's unclear is how well do these devices do it? Are they different? And so we'll talk about that a little bit later. Now, also as part of this oscillating lung therapy, we could be applying PEP, especially in spontaneously breathing patients. And that could potentially be aiding in lung inflation, or could help with alveolar recruitment, giving them a little bit of a break. So it's not uncommon for folks to apply high frequency for 2 minutes and then apply PEP for 2 minutes and then apply high frequency for 2 minutes, mainly in those spontaneously breathing patients. You really can't do that with a ventilator because a ventilator is already giving you PEEP, right? And so these are the different therapies that a lot of these devices provide. In addition, they provide nebulization of inhaled medications. Now, that could be bronchodilators, it could be antibiotics, it could be steroids, it could be a lot of different things. But generally speaking, the aerosol that is given concurrently with oscillatory lung therapy is going to be normal saline. Some people use hypertonic saline. Well, here's the thing. We did publish a few papers over the last couple of years showing the kind of the delivery efficiency of these different devices with their integrated nebulizer systems, and they're all very different. And I didn't include a lot on that right now, but we can certainly talk about it at the end of the lecture. Um, Now, here's one thing that I think is important is, most people are empirically going to give a 0.9% saline treatment. Maybe they put 6 mLs or so of the liquid in the nebulizer, maybe less. And then they apply this because that's what they've done all along, right? Whether they've used the Metaneb or, the IPV device. And that has become the standard of care for thinning the mucus. That's what it's thought. And so again, this therapy can be applied in spontaneously breathing patients with varying between the PEP and the oscillatory, or it could be integrated in line or placed in line with a mechanical ventilator using a whole separate strategy that we're going to highlight today. So where's the clinical evidence around all of this? And the first year or so, I just exhausted the literature and asked myself the question, all right, well, these oscillatory airway clearance devices sure have done a good job showing that you can improve gas exchange, especially in critical patients that have the device in line during mechanical ventilation. But, how much of that improvement in gas exchange is actually related to improvement in lung recruitment and the distribution of lung volumes, which we see obviously with the high frequency oscillatory ventilators, or is the improvement in gas exchange related to removal of secretions? And I think it's probably both. However, no one's really quantified the removal of the mucus from the airway. For instance, they've never really gone in and captured the mucus in a trap and said, all right, sure enough, it's definitive. We were able to remove secretions from the airway. So if you don't have this, then you can say that, a lot of this is going to be based on personal experiences. And I'm sure we can all think of a time where we were taking secretions out of someone's airway, whether it's an ET tube or it improved the cough of a spontaneously breathing patient. I've applied IPV. Prior to moving to Seattle, I worked at Mead Medical Center, and we applied this all the time in CF patients and patients with muscular dystrophy, and yet, sure enough, that secretions came up. But no one's really reported on this. So really, the remaining questions that I have, and I think that everybody has, whether they realize it or not, is the primary effectiveness related with these OLT devices related to improved airway clearance, or is it, really the fact that we are distending the airways, we're reducing the airway resistance, and we're popping lung units open, and by doing that, we're somehow improving the gas exchange, but also helping to facilitate the movement of the secretions. Um, you know, I think it's a little bit of both, but it really hasn't been validated clinically. Are these devices more effective in removing secretions to patients that have mucus trapped in the distal lung regions versus the central airways? That's a really great question, because we think about, say, in the critical setting at our hospital, and we got a bunch of ECMO patients on, and their lungs are completely inspissated and completely opacified with what we think are mucus and inflammatory cytokines and a bunch of just exudate. So it's likely that the entire lung's full of that. So would this be effective in applying to these patients to hopefully get them off of ECMO? Or maybe you have a patient that has a right upper lobe or some lobar collapse, and you want to be able to remove the secretions. Are we able to get deep down in the lung in those areas and get the mucus out? And the question is still unknown. Even with all my testing, I really can't say for sure. But hopefully we'll be able to get there to determine where is the secretion, how are we mobilizing it, how are we reinflating the lung after we have removed the secretions, and overall, how effective is this treatment? Does nebulizing with saline actually improve the efficacy of oscillatory therapy? And, I think the question there is, how well do these devices actually nebulize the saline? Is there a large residual of liquid remaining in the nebulizer after the treatment is considered done? That seems to be the case with a lot of these devices that use the jet nebulizers. could it potentially be improved by using a vibrating mesh nebulizer in line? Could we be able to get more of the secretions out? And honestly, we have tested this, and I don't think that we have appreciated the difference at this point. And I won't spend too much time on that because most of this was done in an ex vivo model of a pig lung. So hopefully we'll be able to study more of this in actual pig lungs that are live and have a true mucus lining in the lung. Does cycling between PEP and OSC improve secretion removal, or is it potentially better than using just the oscillatory mode for this therapy? I think, that all has to do with patient preference, and if the patient tolerates it a little bit better and they can have a little bit of a break in between, that's great. But what are the physiologic effects of this? What is the benefit of this? And can we be able to realistically evaluate this in the lab setting? Are there differences in the performance of different oscillatory devices? I can say now with a lot of confidence that each device performs very differently, whether it's the byways or it's the metaneb or some other device like the IPV. They all have different flow characterization, different pressure profiles and waveforms that actually contribute differently to secretion mobilization. Is the treatment less risky and potentially more effective when OLT is applied directly to the artificial airway of patients? Well, the question is, can you support their ventilation with this device? I mean, in essence, they kind of do behave very similar to an oscillator. Is it possible that we could support their gas exchange, their CO2, and their oxygenation in the short term while we apply this device to those patients rather than putting it in line with a ventilator? And I'll speak to that a lot during this lecture, and what the advantages and disadvantages of that may be. So this is really the only bit of evidence we have out of children's hospitals. And I apologize, I do focus a lot on children in these cases. I think children are specific, especially important because they have much smaller airways. A major reason why they're admitted to the intensive care units or admitted to our hospital, especially during this time of the year, is because of lower respiratory tract infections. Folks have done some testing in chronic patients, specifically with BPD, CP, neuromuscular weakness, and what they've demonstrated, even with, and I'm not 100% clear what device was being used for OLE during these studies, but they were able to show that it was more effective than the CPT, which was applied with a vest in patients who, had these respiratory events and required hospitalization because they had chronic lung disease. And what I think is interesting is that if we look at all of these things, those are big differences, right? In the number of events that patients have, these defined respiratory events, steroids, lower respiratory tract infections, and even bronchodilator use, and seems to have some effect on the rate of hospitalization. And so I think this is also important because a lot of these patients could potentially go home on these devices. And so we have to make sure that we have these devices available to them, and if they are more effective, then there's potential that we could keep them out of the hospital. And so I think this is a great study. It, was retrospective for whatever that's worth. But definitely the only shred of evidence we have right now that's meaningful related to these devices in children. A lot of the other ones just basically show improved gas exchange and don't necessarily look at these major outcomes that we consider important. So if we go way back to 1989, there were several studies that applied a ventilator with PEEP and a high frequency oscillator to the airway. And these engineers were able to go in and modify the way that the flow was going into and out of the airways. And what they did is they took lambs and made an incision into the right middle lobe and injected artificial mucus into the lungs of these animals. And they instilled it at a rate of 1 milliliter per minute, did 6-hour experiments, and basically had them on this device the entire time, whereby they were able to manipulate the pressure waveform, manipulate the time that they applied the pressure and the flow. And basically what they did is they compared the device using an inspiratory HFO bias, or a situation where the flow was on inhalation was equal to the flow on exhalation. So this is just showing the oscillatory flow waveform over time. And they show that, on inhalation, maybe there was a little bit more, or it was equal to the expiratory. And so a lot of the devices like the Metaneb and the Velara will apply high frequency oscillations like this, where, either the inspiratory flow is greater than the expiratory flow. That would be the flow bias, where peak inspiratory flow is greater than peak expiratory flow, um, or it's equal, just like an oscillator. Now, what they also did is they looked at the device when they were able to manipulate the flow waveform to look more like a cough. And so when I say microcoughs, I mean this is the slow inspiratory flow going in, and then on exhalation, we have a much higher flow coming out, right? So the tidal volumes don't really change. It's just how you're dispersing that flow throughout the expiratory time. So in many ways, that's very similar to a cough. And this is similar to how the Byways Clear works and how the intrathoracic percussive ventilator by Bird and now Centec work. They both have a expiratory flow bias. And so what they did is they looked at the artificial mucus output, and they looked at how much was going in versus how much was coming out into this collection flask. And sure enough, there were some positional changes that enhance the removal of secretion through gravitational drainage. And just by placing the animal in, more of a semi-Fowler's position, we're able to get more of the mucus out when you have an expiratory flow bias, meaning the expiratory flow exceeds the inspiratory flow. And similarly, you see that we're getting more of the mucus out here than if we had a inspiratory flow bias or a symmetric waveform that's being applied here. So even with the animal with the head down a little bit at like 20 or 30 degrees, we weren't getting much out at all when high frequency was combined with the ventilator. So I think that really was kind of the premise by which we should have been developing these devices. And, the ability to mobilize the secretions, what we hypothesize is that this is really how the effectiveness or the efficacy of these devices is identified. So with the Byways Clear, you're getting an inspiratory flow, which is going to be slightly greater than a lot of the other devices. It has a dual blower design, provides slightly higher pressures. What you said is kind of what you get, right? Whereas with some of these other devices that incorporate a single limb circuit and they have a fairly large leak because they don't have an expiratory pathway, then they have to exhale their CO2 to air, much like BiPAP. Then what happens is you lose a lot of the pressure through the system. But in these devices, what we've recognized is that the peak expiratory flow is less than the peak inspiratory flow. And so we think that could be important because in this case, the expiratory flow is higher than the inspiratory flow. All right, enough about that. So our general hypotheses have included, that are these small differences in the pressure and the flow profiles of different oscillatory therapy devices, could they be translated into meaningful effects on secretion mobilization? And so, of course, we got a grant from folks to evaluate external chest wall compression or the therapy vest in mechanically ventilated pigs using the same methods that were outlined in the goat study. And so these animals were supported with ventilators. We were looking at electrical impedance tomography, looking at advanced lung mechanics, and we were all ready to go. We figured, why not? You start with kind of the sickest patients, and let's just see how well these things work. And what we showed is we were able to get some of the mucus out. We were able to recover some of the mucus with the therapy vest, but when we applied the different devices, we showed that most of the stuff that we put in, we did post-mortem necropsy on these animals, and most of what we were putting into the lung was just retained in the bronchial tubes. And you can see here that we dissect I think that was the lobar bronchi, that was the right middle lobe. And you can see that all of the airways are just completely inspissated with an artificial mucus simulate that we developed or we worked on. And so, as expected, these animals didn't do so well. And part of the reason why they didn't do so well is because the mucus, when you're providing the oscillatory therapy, with positive pressure ventilation, you can see that it's oscillating, but the mechanical ventilator is coming along and pushing the mucus further down in the lung. And those effects are much greater when you're using a device that doesn't have an expiratory flow bias. And so we went back to the bench and we said to ourselves, well, what did we learn from the animals? And let's go back to them later. And can we do something similar on the bench without, having to deal with actual live animals? And so we didn't really get much out with any of these oscillatory devices. And with the vest, in the couple of subjects that we tested, we were able to get about 22% of the mucus out. They were very, very sick. And so prior to the mucus installation, the CO2s were normalized between the different groups. Following mucus treatment, we identified that the CO2s actually went up quite a bit during the therapy vest. Therapy vest is going to compress the chest wall and it's going to act on the external chest wall, whereas these devices, the Valera and the Byways, sorry, that was the Byways, and this is the therapy vest. Whoops, we got those backwards. Therapy vest, Valera, and Byways. These devices are going to act intrinsically on the airways and help to eliminate CO2. So I apologize for the mislabeling of that. Overall, what we found is that they didn't really get much better after the airway clearance therapy. The CO2s actually kept going up, and a lot of that was a result of the mucus retention in the lungs. And the PaO2, obviously, when we started instilling the mucus, it went way down, and that's on 100%. And we did see with the byways clear that the PaO2 was quite high, but that had nothing to do with mucus removal. What that told us is that we are able to support most of their ventilation and their oxygenation. And at one point, I kept the animal on the device for several, by at least an hour or two, and continued to get blood gases in it. And it looked like this device was providing enough more support than the mechanical ventilator. It was more effective at providing the support. So what we learned from this is that maybe in the future, if we needed to take them off of the ventilator to do the therapy, then this device will support them as long as we're adjusting the settings to get a good chest wiggle, much like we would do with the high frequency ventilator. But I am in no way promoting this as a high frequency ventilator, just as an airway clearance device. And, we do what we need to do to get them to work. So in a spontaneously breathing patient, when you apply these different devices, we can appreciate that in the absence of those positive pressure breaths that we're using with the mechanical ventilator, we're generating a negative pleural pressure in our pleural space. And so that kind of changes the way that the mucus behaves in the airway. So if we put the mucus into the airway, and this is a 3D printed lung of a human with a bunch of celastic lungs hooked up to it, you can see here that the mucus goes down a little bit, but then tends to come out with these devices a little bit better during spontaneous breathing. So they're probably going to be, a little more effective in this case than putting them in line with a ventilator. So with that being said, there was a lot of developments that were made to the Byways Clear device in an effort to have more of an expiratory flow bias. And, in the process of evaluating these devices, we had to switch our in vitro lung models up considerably. We started with 3D printed upper airways of children and adults, and then we had adult tracheobronchial trees with these celastic lungs on there. But, this really didn't represent the true nature of the underlying pulmonary pathology and alveolar recruitment. It was just a very simplistic model. So what we did is we kind of went from here onto using a more sophisticated ex vivo lung. So what we've done now is we've taken a pig that's around 30 to 35 kilos, taken their lungs, and we've put them inside of this plethysmograph, and we've applied a piston pump or a lung simulator to the inside of this sealed plethysmograph so that we can inflate the lungs, much like we do during spontaneous breathing. And so if you have the realistic 3D printed airway on there, whether it's an adult or a child or baby, that makes it a little more realistic when it comes time to apply a face mask or mouthpiece. Takes into account the upper airway resistance and how the oscillatory pressures are going to be attenuated through the airway. And so this is kind of the best thing that we have right now, prior to going to animals or into humans, to evaluate the effects of these different devices. This is Blucas, and basically it's a polyox material. We worked with Bruce Rubin, who is kind of a pioneer in mucus and all things secretions, and he provided us with a recipe for making this artificial mucus here, and we dyed it blue so that we could see where it was going. Since then, we've radio labeled it and used it under scintigraphy, and it's a very realistic mucus preparation that retains a lot of the similar viscosity and viscoelastic properties as human infected secretions. Our in vitro studies for the spontaneous, again, we used the 3D model, we used a mouthpiece, we focused on using a pediatric lung because that's what was available to us for pig lungs, and then used a small child upper airway, had the pig lungs within the plethysmograph breathing at about 25, tidal volume of 200 with a 1:2 IE ratio. And what we did is we instilled 40 milliliters of this Blucas into the trachea with 2 separate aliquots of 20 ml. So basically we had the system oscillating with different devices, the IPV, the Valera, the Byways Clear, and we instilled the Blucas into the distal trachea at time point 0, 20 mLs, and then we oscillated for 10 minutes. And then we added another 20 mLs and then oscillated for another 10 minutes. And then whatever we got into that mucus trap that you see back here, that's not really a good picture of it, but we were able to take that and reference it to the total amount of Blucas that we went in there, and that's expressed as a proportion or a percentage of what was put in. How much did we get out? So that just makes it easier for us to evaluate these different devices. And so we applied the oscillatory therapy, and this was 3 different times, but we've now done it 10 different times. And so we'll be presenting some of these data at ARC this year, and then working on a paper showing these different devices and how they behave with spontaneous, but also when we put the device in line with the ventilator. And so what we showed is with this lung model, we're able to use a pressure of 30. So it's almost identical to the pigs that we treated, you know, and albeit these lungs, you know, they probably don't have the mucus lining, they're surfactant deficient, so they're very sick. Nonetheless, we humidify each of these lungs, and we use a new set of lungs with each different treatment. We humidify them for approximately 30 minutes, and then we ventilate them, obviously with the humidification in line, and then we instill Blucas into there while we have these different devices going. And what we did is we used the devices at the same peak inspiratory pressure as what we were using during assisted mechanical ventilation here. And we've done up to, I think, 8 in each of these groups, so a total of 24 measurements. So with our in vitro findings, what we show is, you know, first I want to call this out, the delta pressures. The delta pressures are going to be the difference between baseline and PIP. So the total delta pressures, the peak and the trough, those are going to be reflected here as no therapy. That's just during spontaneous breathing. So we're only generating a small transpulmonary pressure here. These are the flows that we're generating during inhalation and exhalation. This shows the expiratory flow bias. Basically, you take this value minus that value, and that's what you get. And then if you express them as a ratio, peak inspiratory flow over peak expiratory flow, we see that that's 1.6. And the lower you go, the more effective secretion management or mobilization will be, because you have more of this expiratory flow bias. And overall, we showed that the IPV device and the byways clear, they definitely have this expiratory flow bias. So they're producing these micro coughs, whereas with the Valera device, this device more favors inspiratory flow and has a fairly low expiratory flow in this case. And so, another thing that's interesting is with each of these devices, you increase the peak inspiratory flow beyond what they're breathing, right? And some of them are higher than others. And so we'll speak about that a little bit later here in a second. So what I wanted to show you is that even during normal tidal breathing in this model with the 3D printed airway and the pig lungs attached, we're getting approximately 30% of the mucus out. I mean, that's with the model at essentially 0 degrees, so we're not angling it at all. With gravity dependence, we'll see much more of that coming out, but it's really flow that kind of predicts how much of the secretions are coming out, but it's also the delta pressures and the timing of those delta pressures and the effect that has on the flow. So with the IPV, we see quite a bit of the secretions becoming eliminated from the airway and going into the trap. With the Valera, we don't see as much, and it's not really that much different from just normal spontaneous breathing. And with the byways clear, we see somewhere between 60 and 80% of the secretions being removed. And so each one of these devices does it a little bit differently. The byways clear is going to have a different I to E ratio for their oscillation as the IPV. And we know that with the IPV, it's going to, have a shorter inspiratory time and a longer expiratory time. And that really helps to facilitate the secretion movement, even when you're dealing with lower delta pressures and lower flows. And so, you can see here that their expiratory flow bias is approximately 30. With the byways clear, it's about 20. Nonetheless, I think applying this at a higher pressure significantly allows the secretions to come out of the lung a little bit better. So it's kind of, what do you want to do differently? Do you want to use slightly higher pressures, or do you want to use, do you want to change the timing by which you're putting the gas into the lung and taking it out? So, overall, these were very effective therapies for getting a majority of the secretions out of the lung. And so this brings us to the question about applying this device in line. And so I always thought that putting this in line probably wouldn't remove mucus. In fact, I've done it, and I've never seen anything come up through the breathing tube. And I just thought, like, wow, everybody does this. It's easy, I guess, to put it in line and just let it do its thing. But in essence, there are some safety features related to this. You have to turn the flow trigger off. That's going to limit the ability of the patient to actually synchronize with the ventilator. If the RT is using, depending on the mode they're using, they almost always have to go into pressure control, right? You got to use pressure control. And I think each ventilator behaves a little bit differently because they have different flow control valves and different expiratory valves. If an RT forgets to put the settings back to the pre-treatment values, and this could add to, patient complexity, deterioration, and safety concerns. And you have to be careful, I think, with some of these devices, because if they time out, not so much the byways, but some of the other devices, if they time out and you've got them in kind of an automated mode, if they time out, then you could just be ventilating the room at that point, right? And so there's lots of things that I think are an issue, but the major issue here is that we have demonstrated time and time again, when you apply these in line with a ventilator, you are not going to get the pressures that you've set on the device. It's not going to happen. And a lot of that has to do with the fact that the ventilator is designed to vent any excessive pressure beyond the PEEP level and the pressure control level using a pressure control learn algorithm. And that significantly attenuates your oscillations in the circuit and in the lung. And when we look at how these are transmitted down through the lung, very little of that pressure that you've set here, even though you set that at 30 and maybe you're getting 10 for PIP here, very little of that is being transmitted down into the lungs. So we have to take that into consideration too. Not only are we running some safety risks, but also we're putting it in line with the ventilator. The valves are going to open up. You attenuate some of that pressure when it goes down to the lung anyway. So I think you need higher pressures than what you're getting when you place it in line with the ventilator in order to have sufficient mucus clearance. And so what we did is we, took the byways clear after the final software release, placed it in line with the ventilator. And there were lots of things that we were trying in order to improve the therapeutic effect with these flow and pressure waveforms. And what we were showing is that when you set your oscillation at 25 centimeters of water pressure, and maybe you're ventilating at 30 or 25, you're on the expiratory phase, and that's kind of where these devices work the best. The flow's coming out, and we're applying these oscillations, and they're dipping down. But if we set that oscillatory pressure at 25, why is it only going to like 12? It's because the ventilator expiratory valve is controlling the pressure in the system so that it's preventing it from going above 5 or 6 or whatever you set out as your PEEP. So it's going to the atmosphere, and you're not getting those therapeutic benefits. And so most of them are approved in line with the ventilator, and they still will work. But you just need to keep in mind that the active PEEP exhalation valves are going to attenuate this. You may have muted effects on secretion mobilization that you have to take into consideration, but also keep in mind those positive pressure breaths are going to move the secretions down. So it's like all that work you did during exhalation could be obviated by this positive pressure breath that's just moving the secretions back down in the airway. So that's something you need to consider. And then what we showed is if we were to remove the patient from the ventilator and we apply it directly to the endotracheal tube, and we bleed in oxygen at, say, 10 or 15 liters a minute, we're able to observe these higher flows, and you get more of that flow bias, right? So this is down around 205, and this is down around 190. More of the oscillation pressure, obviously, is going to be transmitted to the patient, even through the endotracheal tube. And so with that in mind, we thought about our pigs and how they had very poor gas exchange, poor oxygenation. And then we put them on this device, and they actually improved better than when they were on the conventional ventilator, when they had a ton of mucus or simulated mucus trapped in their lungs. And we realized, well, maybe our patients will tolerate this. And so when we consider even the IPV device, which is widely used in line with a mechanical ventilator, same thing. We don't really have the expiratory flow bias here. It planes out because of the expiratory valve. There's massive attenuation in the pressure, and those oscillatory volumes are negligible. So how effective can they be in removing the secretions? And so I went on to just do a simple study where we were providing positive pressure breaths with a mechanical ventilator, and we put the byways clear in line with the ventilator, and we got out about 35% of the mucus. When we took them off and we were actually bagging them, that was a little bit of an issue because you had to make adjustments on the PEEP valve in order to get positive pressure into the lung. But we tended to have more of the secretions being removed when we removed them. We took it out of the inline phase and put the oscillatory device in line with the bag and the ET tube. So we got a lot of the mucus out here. And, obviously you'd have to put your PEEP on your bag at 20 to preserve a lot of the positive pressure oscillations that are going into the lung. Now, when we hooked it directly to the ET tube, this was just for a couple of runs. I was seeing that all of the mucus was coming out, and I'm like, okay, cool. This would be different now, I think, in the pigs. If we were to go in there and apply this directly using the new algorithm, we would be able to get a lot of the mucus out, and we'd have better outcomes. And so with this being said, we went with our in vitro models. We mechanically ventilated the pig lungs that were within the plethysmograph, and we used the one-way valve placed in series with the inspiratory valve with the handset. And I'm not really sure you need the handset in this case, but we did use it. We did not apply nebulization, but we evaluated mucus recovery without any treatment at all. And you could see, it's a little less obviously than than with spontaneous breathing because it's pushing the mucus down into the airway. And then we applied the IPV, the Valera, and the byways clear during mechanical ventilation. And as you can see here, we're typically in that 35 to 45 range, with the byways clear and the IPV having similar outcomes on mucus recovery, with the Valera having much less. And I think that has a lot to do with the pressure that's lost through that little expiratory valve. When we apply it directly to the endotracheal tube, we're preserving a lot more of that pressure. And what we were able to show here is that like 90 to 100% of the secretions were able to be removed from the airway when we place it directly to the endotracheal tube. And so, the summary of our findings are that this high frequency assisted airway clearance, or OLT, can mobilize 70 to 100% of airway secretions when it's being applied properly. And this is kind of different from what the company suggests. This is different from what we've all thought about in the past. But, when it comes to mechanically ventilated patients who really need a lot of help with secretion management and clearance, it may be better to go directly to the ET tube. When the therapy is applied in line with the ventilator, the secretions tend to pool, pushes it further down into the lungs during inhalation, active inhalation of the ventilator. PEEP exhalation valve reduces the oscillations, making them less effective for mobilization. Therapy can be improved by removing patients from the ventilator or reducing mechanical support. Maybe you're still going to get 35% of the mucus out. So it just means you'll have to do it longer potentially, or consider putting them into a CPAP mode, which may or may not preserve more of those oscillations, most likely not. So we've worked on developing these software algorithms to improve the efficacy of how they're being used with mechanical ventilation. But overall, that's our key finding is that it's better to probably remove them from the ventilator. And this is just kind of a brief overview of what our recommended clinical guidelines are, both in spontaneous breathing non-ventilated patients. And I can send this to you. I want to leave time for questions, but I can send this entire lecture over to you guys so that you can have these guidelines if you're thinking about using these devices a little bit differently, or you're fine using them just the way you are. It's just kind of our experience and how we're bleeding oxygen into the filter. This is basically our application in intubated or tracheotomized patients that are getting ventilator support, and some key tenets and some suggestions on how to do this appropriately. And so this is what we're currently using. So can't really spend a lot of time here because I want to leave time for questions, but also some guidance on aerosol therapy, where we're using 0.9% saline for each of these treatments. There is potential that by applying bronchodilator therapy, as long as you get the majority of the secretions out and they're less obstructed, you could use this device to enhance the distribution of the aerosol down into the distal lung regions a little bit better, which I found particularly interesting. I think with oscillation, we're getting like 20 or 30% in the lung. I didn't include some of my publications recently. We have kind of guidelines on hypertonic saline and mucolytics. We worry a little bit about giving those in line because of the occlusion of the byways clear filter and the effect of the resistance on the overall attenuation of the oscillatory pressures. And so maybe we at least proceed with caution and use these a little bit more sparingly when we're applying them in line. Anyway, so these are kind of just those basic guidelines. I'll be glad to take some questions now if any of you have them. I will send this PowerPoint along to Leah so that she can distribute it to all of you if you're interested.
Excellent. Thank you, Rob. So we do have some questions as well that are in the Q&A box. Are you able to pull it up so you can read it?
Yeah, there we go.
Okay.
Okay. So the question here is initial settings. What are the recommended initial pressure and frequency settings for oscillation lung therapy, non-ventilated to ventilated patients, are there specific adjustments based on size? Yeah, and secretion burden. So what we decided is that we would, you can kind of do the stealth ninja thing where you go in, you just start out really low. And if the patient's tolerating it, you can just turn it up. I know that I've learned stuff from other folks who are using this device and also have been seasoned users of the IPV device where, you can apply different frequencies and different pressures if you're not getting the secretions out in real time. And so just by doing that, you can potentially increase the oscillatory volume. And maybe, people have said that by using higher frequencies, you're going to shear more of the mucus off the airway wall, and then you turn the frequency down to get them out. So there's lots of approaches, but I think for the most part, in our spontaneously breathing patients, we're going to start them right here. Oscillation of about 20 to 25 with medium frequency setting. And then from there, you can make some subtle adjustments in the oscillatory pressure and the frequency. And sorry, that is actually on screen 1 right here. And I think I pulled it off, but can you see this?
Yes.
Yes. Okay, good. So this is basically how we're applying the oxygen therapy, suggested initial settings that we're using. And is this right? I don't know. It's just kind of kind of what we're doing, and we're fairly new to it. So we always like to make sure that we have something in place that, is based on some evidence. And so, yeah, oscillatory settings of 20 to 25 with medium frequency. But I always generally would tell people to start lower and then inch it up a little bit. So, also if they're having issues and maybe they're hyperventilating and they're uncomfortable using the oscillatory pressures, it's always, probably a good practice to cycle between PEP and OSC, using that automated mode, or doing it manually, whatever you think you need to do in that case. And so, that whatever the patient tolerates. Hopefully I answered your question. So patient size, lung compliance, and secretion burden. Well, we don't really know what their lung compliance is. If they're on a ventilator, we do, and with a ventilator, we're always going to generally set the oscillatory pressures equal to their peak inspiratory pressure. You may consider using them slightly higher if you need to, or, lower. So just manipulating the pressures may enhance secretion removal. At least that's what I've seen in the piglet models. Therapy documentation from Jennifer. She said, questions on therapy documentation. What key parameters should be documented during oscillatory lung therapy? Pressure, frequency, duration. Yeah, all of those things. Are there standardized documentation templates or best practices for EMR documentation? Okay, so I probably need to get you, Jennifer, my email, and I will send you what we have. I'll send you our airway clearance protocol as well. For anyone that's interested, I can send that on. In fact, I could just send that on to Leah now, and then I can get all of the different things that we are documenting. But yes, all of those things are what we are documenting. And then Jennifer had another question. How do you determine when to escalate or de-escalate therapy settings? Are there contraindications or precautions for initiating therapy in pediatric versus adult populations? And I think, I kind of skipped over this based on time, but we talk about here the indications. And this is directly from our airway clearance pathway that we recently launched, and it was a 2-year work in progress. And, we kind of held out and were deliberately aloof initially, because we were waiting for the byways clear to come. So we made this airway clearance pathway, which I think will be helpful for all of you. These are our indications, contraindications, and these contraindications are similar, I think, between adults and children. These are some of the adverse conditions that you could expect. And then these are the, jumps right into our recommended clinical guidelines. So hopefully that answers those questions.